Okay, so we are starting. Ready? Okay, so first of all, we in the first half of the class, we will be finishing up the applied aspect of calcium metabolism, which was left in the last week. Then we will move into the endocrine part of the pancreas, and that will be continued in subsequent classes. So endocrine pancreas means the insulin, the glucagon, diabetes, related disorders. We will be discussing in subsequent classes. We will be starting from today, that one. So coming to this, first of all, applied aspect of calcium metabolism, first disease that we will be discussing, that is tetany. Any idea what happens in tetany? So spasm, and spasm means what? So it's usually a spasm of muscles, skeletal muscles. So why that happens? Due to low calcium. Okay. Now tetany is usually a muscular which actually happens due to increased excitability of biomembrane, excitable membrane, skeletal muscle membrane, increased excitability due to low calcium. So tetany overall, there is increased this happens due to lower calcium. So most common feature that we find in tetany is carpopedal spasm. So carpopedal spasm কি হচ্ছে অনেক সময় দেখা যাচ্ছে if you have a carpal area তে যদি if there is a contraction excitability what will happen, it will take a shape of this, হাতটা এরকম হয়ে যাবে পেশেন্ট গুলো। তো এই ক্যালসিয়াম যদি কম থাকে অনেক সময় we can find this kind of features. So why this happening? What are the conditions associated with this? Calcium কখন কখন কমতে পারে? Any idea? Calcium কখন কমতে পারে? তাহলে তো সেই হিসেবে all males are hypocalcemic. Parathormone কমে গেলে, great. So basically there is out after post surgery. The surgery may be related to the thyroid gland where parathyroid is injured and thereby hormone secretion is down, parathormone secretion is down. The surgery may, and this may also be due to surgery in the parathyroid where itself these are out, whatever be the reason. So সেক্ষেত্রে এটা কমতে পারে. Okay. There might be some scenario where parathormone level is normal but the receptors are not working. In that case also we will be getting a condition where serum calcium will be low. Parathyroid টা বেড়ে যেতে পারে, parathormone levelটা হয়তো বেশি রয়েছে because receptors are not working. So defect in parathormone receptor parathormone. So if the receptors are not working properly, hormonal level টা বাড়িয়ে দিলেও you will not get the ultimate function. So again this can happen. আরেকটা যেটা ভীষণ ইম্পর্টেন্ট যেখানে you can get this hypocalcemia, this alkaline, we can get hypocalcemia, and one of the commonest Manifestation which may lead to alkalosis is hyperventilation. প্রচন্ড জোরে শ্বাস নিচ্ছে, ভেরি কমন ইন অ্যাংজাইটি, অ্যাংজাইটির পরে হাত পা এরকম হয়ে যাচ্ছে, দ্যাট ইজ হাইপারভেন্টিলেশন, কমন, মোর কমন ইন ফিমেলস। সো হাইপারভেন্টিলেশনে, অ্যাংজাইটি ইনডিউসড হাইপারভেন্টিলেশন lead to low calcium and subsequent ventilation কি করে অ্যালকালোসিস হয়? any idea? Hyperventilation তো বুঝলাম, মানে very frequent, air is going inside and air is coming outside, kind of that hyperventilation. And alkalosis কি করে হচ্ছে? হ্যাঁ, so basic thing is, yes, so basic reason why H2O plus CO2, H2CO3, correct? That's an acid. So carbon dioxide যদি বেরিয়ে যায় continuously, we'll be getting a respiratory, it's a volatile acid. So if it goes out, there will be respiratory alkalosis. সেখানে এই ধরনের একটা সিচুয়েশন আসতে পারে। To some extent other areas like vitamin D deficiency doesn't usually come as this, but theoretically there's a possibility that D deficiency can also lead to this kind of condition. Maybe theoretically also there's a possibility if calcitonin level is very high, either pathologically or by some other means, there is a theoretical possibility that serum calcium level will also go low. However, these things are quite rare and more or less theoretical rather than that we find day in and day out. So most common cause is parathyroid deficiency and second is alkalosis. These are the conditions which are associated with tetany. Tetany is quite an important science actually, and this science you need to remember. So একটা sign হচ্ছে if you put a cuff around your arm and if you keep it inflated for some time, the carpopedal spasm or carpal spasm will be initiated, precipitated. So কাফটা কিছুক্ষণ যদি বেঁধে রাখো, তারপরে আমরা দেখবো যে কার্পাল স্প্যাজমটা হচ্ছে, and we call it Trousseau sign. Trousseau sign কি হচ্ছে? It's a very peculiar spelling. Trousseau sign কি হচ্ছে এখানে? Basically you are putting pressure, sustained pressure on arm. Already due to hypocalcemia, membrane excitability is high. So along with that, whenever we are putting a physical pressure on that, physical force, already chemically membrane excitability high হয়ে রয়েছে, তার সাথে যে moment একটা sustained physical force we are putting, membrane threshold খুব তাড়াতাড়ি reach হচ্ছে and action potential and depolarization and everything is generated, because this spasm which is happening, it is depolarization. It's only depolarization, nothing else. Muscle function শুরু করছে মানে কি? There is depolarization. Depolarization কেন হচ্ছে? Membrane excitability high. Excitability high মানে কি? If you remember about the action potential, the membrane threshold যেটা কত ছিল in case of neuron -55, সেইটা আরো নিচে চলে আসছে। You do not have to reach up to -55 to be activated, because calcium level is low, excitability is high. It be a condition your resting membrane potential is -70 and around -63 you are reaching threshold. So মাত্র 7 চেঞ্জ করলেই you are getting excited. That's all about this. সেম আমাদের যে কনভালশন হয় এখানেও একই মেকানিজম কাজ করে, সিজার যেটাকে বলে কনভালশন, মৃগী রোগের সাথে যেটা আছে, সেম থিং, থ্রেশহোল্ড কামস ডাউন ডিউ টু এনি রিজন. ইট মে বি ব্রেন ডিসঅর্ডার, ইট মে বি ইলেকট্রোলাইট ডিসঅর্ডার, হিয়ার ইট ইজ ইলেকট্রোলাইট ডিসঅর্ডার, ক্যালসিয়াম কমে যাচ্ছে তাই জন্য হচ্ছে। ইফ উই গো ইনটু ইভেন ফার্দার ইন মলিকুলার ডিটেইল হাউ দ্যাট হ্যাপেন্স, বেসিক্যালি হোয়াট হ্যাপেন্স, the calcium in ECF, extracellular fluid, এবং মাথায় রাখবে this extracellular calcium is coupled with sodium channel which is present on the membrane. So till the time sufficient amount of calcium is present in ECF, sodium channel are coupled with them and the voltage required to open up sodium channel is somewhat fixed. The level calcium channel, or sorry, the level the calcium will go down, the voltage required to open up sodium channel will be lower than earlier. So very early or with just minimal stimulus, the sodium channels will open. Sodium channel open mane ki? Sodium influx. Sodium influx mane ki? There will be depolarization. Clear? So main thing, usually calcium this calcium goes down, sodium channels are now not coupled, or sodium channels are easy to open up যখন ক্যালসিয়ামটা নিচে চলে যাচ্ছে সোডিয়াম চ্যানেলগুলো। So in that condition, in hypocalcemia, sodium channels can open at lower voltage, lower threshold. এই লাইনটা দরকার। Hypocalcemia, sodium channel can open up at lower voltage. এটা কি হচ্ছে? এটাও it is also positive in case of hypocalcemia. এটাই যেটা হয়, if you এই যে TM joint রয়েছে, temporomandibular joint, over there if you just tap, normally করে দেখতে পারো কিছু হচ্ছে না। If you do this, there is nothing. এদের ক্ষেত্রে the moment you do, facial muscle will go into twitching. This তুমি নিজে করে দেখো, প্রোভাইডেড কারো হাইপোক্যালসিমিয়া নেই তাহলে একটা সমস্যা হবে, বাট আদারওয়াইজ করে দেখো কিছু হচ্ছে না, nobody is having any problem. কিন্তু যদি the patient যাদের হাইপোক্যালসিমিয়া হয়ে আছে, if you do this, suddenly everything will go into twitch, and that is very visible, very visible. This is happening the same condition. ক্যালসিয়াম কমে গেছে, সোডিয়াম গুলো hyperactive হয়ে গেছে, sodium channels are easy to open up, depolarization is coming easy, depolarization is cheaper. That's why this is happening. So again, সাইনটার নামটা মনে রাখা, and this is seen in case of hypocalcemia. It's a facial twitch. What is happening? Facial muscle twitch. টিটানিতে এগুলো পাওয়া যায়. How to treat? Definitely we have to supplement with calcium. এদেরকে ক্যালসিয়াম দিতে হবে। আরেকটা মেজর প্রবলেম হতে পারে, if suppose not only here, the patient also may dangerous. Larynx যদি spasm হয়ে বন্ধ হয়ে যায়, হাওয়াটাই যাবে না। So this can be dangerous. Another dangerous factor of this কি দেখলাম? What is that? কোথা থেকে আসছে? ECG তে আছে। Very good. What is QTC মানে কি? Corrected QT. অ্যারো দেওয়া আছে। এটা কি হচ্ছে? যদি এটা বুঝতে অসুবিধা হয়, you just write QT prolongation on ECG. QT prolongation on ECG. এটাও হচ্ছে ক্যালসিয়াম যদি কমে যায়, তার ফল কি হতে পারে? If QT prolongation happens, what can happen? Arrhythmia, and dangerous arrhythmias, patient become dangerous arrhythmias are incompatible with life. So QTC prolongation important point, because patient may go into cardiac arrest. Patient may go into cardiac arrest in such cases. Okay? লেখা হয়ে গেলে next we will be moving into the next disease. এটা ছোটবেলা থেকে সবাই জানে, rickets. Rickets, everybody knows. Clear? Rickets. So এই জিনিসটা বললাম, টিটানি, it is actually an acute manifestation of hypocalcemia. Calcium disorder, it is an acute manifestation, because the things that you are going through over here, you already know, এই জিনিসটা যদি 6 মাস থাকে লোকটা বাঁচবে না। Whatever is happening, QT prolongation, it is a matter of seconds to minutes to hours, that's it. একটা লোক এই কিউটি প্রলঙ্গেশন নিয়ে মানে মাসের পর মাস চালিয়ে যাচ্ছে, ইটস ভেরি ডিফিকাল্ট, হবে না। তার আগেই সামথিং উইল হ্যাপেন, আইদার হি উইল বি কিউরড অর হি উইল বি অন দ্যাট সাইড, যে কোনো একটা কিছু হবে। সিমিলারলি এই জাতীয় যেগুলো স্প্যাজম হচ্ছে and somebody is having spasm for 2 years, not possible, these are acute manifestation। এবারে যে ডিজিজ গুলোতে যাবো, those are chronic manifestation। তার মধ্যে ফার্স্ট ইজ rickets, সেকেন্ড ইজ osteomalacia, থার্ড ইজ osteoporosis। এই তিনটে these are chronic manifestation। এগুলো নিয়ে a person can stay, definitely his quality or her quality of life will be much lower, will multiple complication, but it is not incompatible with life। বহু কালকে মরে গেল, অস্টিওপোরোসিসের জন্য মরে যাচ্ছে এরকম নেই জিনিসটা, it will remain there। সেটার জন্য there might be some fall and subsequent complication, but just osteoporosis মেরে ফেলছে, it's not the case। So we are going to chronic problem in bone development, problem in deposition of salt in bone matrix, and widened and irregular epiphyseal plate. These three things. So basically problem in development of long bones, problem in deposition and strength of, or problem in density of bone matrix, and wide and irregular epiphyseal growth plate. Usually rickets are grossly occupied vitamin D independent ricket. Vitamin D dependent means vitamin D level is low or vitamin D utilization is low, which is leading to reduction in overall absorption of calcium, overall absorption of phosphate. Since body is having less utilizable calcium and phosphate, bones are not getting enough amount of calcium and phosphate to develop its matrix. Epiphyseum is trying to, create more and more bone, je growth plate royeche, but the overall effect is a problematic one. Overall effect is a disfigured condition. কি হয়, লং বোনে বোয়িং অফ বোন হয়ে যায়। ছবিগুলো তোমরা দেখেছো বাচ্চাদের। So basically there is excessive curvature because the tensile strength is low। এবার একটা লোক দাঁড়িয়ে আছে, তার 80 কিলোগ্রাম ওয়েট, যদি লং বোনের টেনসাইল স্ট্রেংথ ঠিক না থাকে, so what will happen? It will move like that। বাচ্চাদের ক্ষেত্রে সেই জিনিসটা হয়। It is mostly seen in the children due to this। Now vitamin D dependent rickets mean it is he or she is not getting enough vitamin D। So if you give vitamin D to this patient, their rickets or their problem will be solved। Vitamin D dependent। What is vitamin D independent? Vitamin D independent rickets যেটা, এদের vitamin D level is okay, vitamin D level is okay, তারপরেও রিকেট হচ্ছে because there is a problem in the receptor। So vitamin D dependent in case of malnourishment, সেইখানে এই জিনিসটা ভিটামিন ডি পাচ্ছে না, ফুডে সাপ্লাই অফ ভিটামিন ডি ইজ নট দেয়ার, সেই জন্য পাচ্ছে না। বা দেয়ার মাইট বি সাম আদার ক্রনিক ডিজিজ, দ্যাটস ওয়াই ইউটিলাইজেশন অফ ভিটামিন ডি ইজ নট হ্যাপেনিং প্রপারলি। ভিটামিন ডির ফাংশন হচ্ছে ক্যালসিয়াম আর ফসফেটের অ্যাবজর্পশনটা ফ্রম জিআইটি ইন্টেস্টিন বাড়িয়ে দেওয়া। কি করে আগের দিন আমি বলে গেছি, 125 হাইড্রক্সিলেশন, অ্যাক্টিভেশন অফ ভিটামিন ডি, এগুলো হচ্ছে। আর কিছু জায়গাতে এই ধরনের ইস্যু আসতে পারে, ইফ দেয়ার ইজ আ রেনাল ট্রাবল, if there is a liver trouble, and liver 25 hydroxylation is happening, renal kidney to 125 dihydroxylation is happening, and these steps are important for activation of vitamin D। Unless vitamin D is activated also, this will not contribute to the bone development or overall nutrition। So vitamin D, if the source is deficient, you are not getting, that's vitamin D dependent। Vitamin D independent, you have vitamin D, but properly। So what will happen, even if you take more than vitamin D, a time will come, active vitamin D is running in your blood, even in higher amount, more than normal, the effect is not there। অনেকে খুব পড়াশোনা করে পরীক্ষায় মার্কস পায় না, that is this। কিভাবে হয় জানি না, বাট প্রচুর কিছু লোক পড়াশোনা করে না, পরীক্ষায় মার্কস পায় না। তাদের কি, তাদের যদি একটু বেশি পড়াশোনা করে, দে ক্যান ডু দ্যাট। সো দ্যাট হচ্ছে পড়াশোনা ডিপেন্ডেন্ট খারাপ মার্কস। আর কিছু লোক প্রচুর পড়াশোনা করে, পরীক্ষায় মার্কস পায় না, সেটা পড়াশোনা ইন্ডিপেন্ডেন্ট খারাপ মার্কস, তার এফেক্টিভিটিটা দেখতে হবে। কিছু লোক কিচ্ছু পড়াশোনা করে না, প্রথম দিন হলে এসছে, হলেই সবচেয়ে বেশি পড়াশোনা করেছে, মার্কস পেয়েছে, এরা আমাদের বোর্ডের বাইরে। তো রিকেটসের মধ্যে এটা, রিকেটসের ফিচার গ্রোথের ইস্যু আসবে, বোনের টেনসাইল স্ট্রেংথ চলে যাবে, দেয়ার উইল বি বোয়িং অফ লেগস which is very common. Patient may also complain of weakness, fatigue, etc. So lot of things. Coming to the osteomalacia. Next one is osteomalacia. Ricket is usually a disease of the children. Osteomalacia is a disease of the adult. Osteomalacia is vitamin D deficiency and related complication in adult. There was a need to differentiate these two classification. Ricket বললেই তো হতো, adult ricket বললেই হতো, the same thing. Adult ricket বললেও তো হতো, আমরা আলাদা একটা ডিজিজ কেন নাম দিয়েছি? Because in adults growth is complete. ফলে চিলড্রেনে মেইন ইস্যুটা হয় গ্রোথে, বোন গ্রোথ ইজ ডেফিসিয়েন্ট রিকেটসে, or bone tensile strength is deficient. But in adults, যাদের ভিটামিন ডি ডেফিসিয়েন্সি ইজ স্টার্টিং অ্যাট অ্যাডাল্টহুড, দে আর অলরেডি কমপ্লিট, তাদের বোয়িং হবে না, তাদের তো অলরেডি কমপ্লিট হয়ে গেছে, তাদের প্রবলেম আসবে লেস, হ্যাঁ বোনসে প্রবলেম তো আসবেই, অ্যালং উইথ দ্যাট ইন দিস সাবসিকুয়েন্ট অর যেগুলো ক্লোজ রয়েছে টু দ্য বোনস, তাতে কমপ্লেনটা বেশি আসবে। ইন কেস অফ মাসেলে কমপ্লেন আসবে, টেন্ডনে কমপ্লেন আসবে, লিগামেন্টে কমপ্লেন আসবে, এই ধরনের কেসগুলোতে। তাহলে ভিটামিন ডি ডেফিসিয়েন্সি হচ্ছে ইন অ্যাডাল্টস, দ্যাট ইজ অস্টিওমেলাসিয়া। পেশেন্ট উইল কমপ্লেন অফ বোন পেইন, উইকনেস, বডি পেইন, প্রক্সিমাল মায়োপ্যাথি, বলবে গোটা গায়ে ব্যথা হচ্ছে, ভেরি কমন গোটা গায়ে ব্যথা হচ্ছে, প্রক্সিমাল মানে শোল্ডারের কাছাকাছি বা লো ব্যাক পেইন, এগুলোর কমপ্লেন করবে পেশেন্ট। তার সাথে দেয়ার উইল বি সার্টেন আদার থিংস, যেহেতু আগের দিন বলেছি ভিটামিন ডি ইজ ইম্পর্টেন্ট ফর ইমিউন সিস্টেম, তাই জন্য দেখা যাবে দেয়ার উইল বি মানে অল্প ছোটখাটো মানে রেকারেন্ট ইলনেস মাইট বি দেয়ার, সবার যে হবে তা নয়, সাম পিপল মাইট হ্যাভ। ভিটামিন ডি ইজ ইম্পর্টেন্ট ফর গুড মাইন্ড, ফলে ডিপ্রেশন, ইরিটেশন, লেথার্জি, দিস থিংস মাইট কাম। এই প্রত্যেকটা জিনিস অস্টিওমেলাসিয়ার মধ্যে হবে। কারা বেশি প্রোন অস্টিওমেলাসিয়া? ভিটামিন ডি ডেফিসিয়েন্সি যাদের হওয়ার চান্স বেশি তারা বেশি প্রোন। কাদের ভিটামিন ডি ডেফিসিয়েন্সি হওয়ার চান্স বেশি? যদি দেয়ার ইজ ম্যালনারিশমেন্ট, যদি if there is no adequate sun exposure, vegetarian diet, তাতেও ভিটামিন ডি level is low. Women অনেক সময় দেখা যায় because of malnourishment or excessive cover up of body, not going to sunlight, there is a higher chance. Plus estrogen has a good effect, so post menopause again vitamin D deficiency may be increased, where we can find this osteomalacia kind of scenario. তাহলে osteomalacia supplementation. Treatment is vitamin D supplementation. Very common, এটা খুব ইউজ করা হয় আমাদের এখানে, ভীষণ কমন। ভিটামিন ডি হতে পারে, you can also have a good diet with rich with vitamin D, you can do that. There are certain molecules which or certain type of habit which reduces the absorption of vitamin D. We have to stop those things, and the best option is supplement with vitamin D. Next in line we have osteoporosis. This is also close to osteomalacia, but osteoporosis means now bone matrix, it is getting less and less dense. So level of calcium, level of phosphate in bone is low. It is multifactorial. Malnourishment can be a cause. Deficiency in vitamin D can be a cause. Deficiency in calcium in diet can be a cause. Long history of disease, chronic disease can be a cause. অন্য কোনো ডিজিজ রয়েছে, ম্যালিগন্যান্সি রয়েছে, লং টাইম, immobility is a cause, lack of exercise is a cause, post menopause that's a cause. কারণ ইস্ট্রোজেন রিসেপ্টর গুলোর সঙ্গে আমরা আগের দিন ডিসকাস করেছি, there is a very good correlation between these two. So as the estrogen level falls down after menopause, osteoporosis is quite common. Osteoporosis এর ক্ষেত্রে there are multiple ways how we can treat it. জাস্ট কয়েকটা জিনিস এখানে লিখে নিতে পারো। এক হচ্ছে প্রপার ডায়েট, সেকেন্ড হচ্ছে সাপ্লিমেন্টেশন অফ ক্যালসিয়াম অ্যান্ড ভিটামিন ডি। ফার্স্ট ইজ প্রপার ডায়েট, হাউ টু ট্রিট অস্টিওপোরোসিস। ফার্স্ট ইজ প্রপার ডায়েট, সেকেন্ড ইজ সাপ্লিমেন্টেশন অফ ক্যালসিয়াম অ্যান্ড ভিটামিন ডি, থার্ড ইজ প্রপার ওয়েট বিয়ারিং এক্সারসাইজ। ওয়েট বিয়ারিং এক্সারসাইজ মাথায় রাখবে, ইফ ইউ লিফট ওয়েট bone density will increase. There is a very good exercise called swimming, কিন্তু এতে bone density increase করে না because of the buoyancy. যতক্ষণ না anti gravity exercise you are doing, bone density will not increase. এখান থেকে one applied aspect comes, if an astronaut remains in space for 2 years, once he comes back to earth, there are two major change in skeletal system. One, his height increases. Yes, আপনি কি 5 ফুট ছিল 6 ফুট হয়ে যাবে না, but there will be some increase, কারণ গ্র্যাভিটি ছিল না, there was no gravity. Gravity is making us this much. আমি এখন যদি অন্য একটা if we go to moon, আমাদের height slowly increase করবে because there is no gravity. So প্রত্যেকটা ডিস্ক আছে, each and every disk will be a slightly, maybe in a millimeter. দুটো vertebraর মধ্যে যে ডিস্ক আছে, maybe in a millimeter. Bones, tendons, they will be under less pressure, so you will rise up. তাহলে হাইট বাড়াতে চাঁদে যেতে হবে। হাইট যদি কমাতে হয়, ধরো বাসে ট্রামে ধাক্কা খাচ্ছ মাথায়, তো ইউ হ্যাভ টু গো টু, কোথায় যাওয়া যেতে পারে? জুপিটার। ইয়েস, অপশন ইজ দেয়ার। তোমার যদি আরো চাই, সো ইন দ্যাট কেস ইউ ক্যান গো টু সান। হাইট বাড়বে আর ফিরবে না, এই ব্যাপারটা। সো বেসিক্যালি দ্য হোল থিং ইজ দ্যাট। সেকেন্ড থিং দ্যাট হ্যাপেন্স, দেয়ার ইজ আ সার্কোপেনিয়া, মাসল মাস সেটা কমে যায় ইফ ইউ স্টে ইন স্পেস ফর আ কনসিডারেবল টাইম, and bone matrix density will also be lost. এমনও দেখা গেছে long term space station the person was there, once he comes back to earth, he initially in first few weeks he was requiring assistance from others to walk properly, পারছে না, because এখানে ওয়েটটা বেড়ে গেছে প্রচন্ড। all of a sudden you feel this thing, সুইমিং পুলে 1 ঘন্টা থাকলে তারপর উপরে উঠতে গেলে you will feel this thing, ওয়েটটা অনেক বেড়ে যায় বডিটাকে তুলবার সময়। যারা যারা সুইমিং করেছে they can feel just 30-40 minutes this can change, that is just a perception change. এখানে দেখা যাবে যে even structural change has also happened. হ্যাঁ, অনেকগুলো এরকম জিনিস থাকে। তো এই কথাটা আমি বলছি because anti gravity exercise is quite important to maintain muscle mass and bone mass, otherwise as the age increases it will go down. Clear? Osteoporosis হয়ে গেল। তাহলে তিনটে ওয়েতে ভিটামিন ডি ডেফিসিয়েন্সি গুলো এগুলোকে আমরা মেইনটেইন করতে পারি। There is some role of calcitonin also osteoporosis treatment we can also use calcitonin. Amra emni last day we have mentioned that calcitonin under physiological condition do not have much effect on calcium metabolism, but in pharmacological or treatment dose calcitonin we can use to prevent osteoporosis. Karon ki that will reduce the serum calcium and that will go into the bone. Basically osteoporosis e ki hocche, bone is losing salts, ক্যালসিটোনিন কি করছে, সল্ট যেটা which is increased in blood, it is again pushing it back into the bone. We use calcitonin as a spray, nasal spray. Nasal spray হিসেবে আমরা calcitonin use করি। So this is all about the calcium metabolism. We are going into the next one, that is the endocrine pancreas. This is the 8.2. So coming to the pancreas, pancreas is a mixed gland and mixed gland means it has exocrine part, it has endocrine part. এক্সোক্রিন কি কি ফাংশন আছে, এক্সোক্রিন ফাংশন অফ প্যানক্রিয়াস কি কি আছে? জিআইটি আমরাই পড়িয়েছিলাম, তাহলে trypsin, chymotrypsin, carboxypeptidase, so those lipase, so basically enzymes for proteolytic enzymes, to some extent carbohydrate digesting enzyme, and very importantly lipolytic enzymes, এগুলো হচ্ছে প্যানক্রিয়াস থেকে বের হচ্ছে। So these are the enzymes. Coming to the endocrine part, head of pancreas, etc. This is exocrine. Very minute area is endocrine, and that is known as so endocrine pancreas has 4 type of important cells. প্রত্যেকটা সেলের আলাদা ফাংশন আছে, highlights of Langerhans and alpha cells insulin. MCQ এর জন্য ভীষণ ইম্পর্টেন্ট। beta cell secretes somatotropin. Not that important for you, that is pancreatic polypeptide. These 4 are very important candidate for MCQ. যার মধ্যে in upcoming weeks including today's class, alpha cell or beta cell, এই দুটো নিয়ে maximum time we will be spending on alpha cell and beta cell, because these are very important from carbohydrate metabolism, fat metabolism, protein metabolism, growth and diabetes mellitus. এই পুরো জিনিসটা থাকবে in maybe, I believe it will take 3 classes approximately to finish this up, including on diabetes. We need to discuss it at least 30-45 minutes, because it's so important. So many questions right from this year you will be getting. At least the pathophysiology of diabetes, you will be getting that. Types of diabetes, approach to the types of diabetes. Definitely types of diabetes is a part of more advanced age, advanced syllabus, but right now at least the approach to it, that you need to know. And you will also come to know that only type 1 and type 2, these are not the only variants. There are multiple other variants of diabetes too. So anyway, coming to this, so insulin that comes up from beta cell is all the hormones and enzymes, they are protein lineage, right? So it is also a polypeptide, and it has thing you need to understand. Initially, from the Langerhans, from the beta cell, there's a molecule of insulin. Leader sequence initial segment which, and once that is cleaved, it comes the initial part, a particular peptide is cleaved from proinsulin, we call it so basically the first precursor molecule is pre-proinsulin. সেইখান থেকে দেখা যাচ্ছে we are getting proinsulin, একটা sequence বেরিয়ে গেলে cleaving of a part of the sequence, তারপরে চলে আসছে proinsulin থেকে C-peptide, as it goes away we get the insulin. Insulin has 2 chains, one is A chain, the other is the B chain, and overall 51 amino acids. Insulin এর মধ্যে 51 1 অ্যামিনো অ্যাসিড রয়েছে। এগুলো তো বই থেকে তুমি মুখস্থ করতে পারবে, এগুলোর মধ্যে বেশি ব্যাপার নেই। বাট ইউ নিড টু আন্ডারস্ট্যান্ড ওয়ান থিং, হোয়াট ইজ দ্য রিলেশন অফ সিগনিফিকেন্স অফ সি পেপটাইড ওভার হিয়ার, এই আন্ডারস্ট্যান্ডিংটা উই নিড। তাহলে ট্রাই টু আন্ডারস্ট্যান্ড ইনসুলিন, ইফ উই লুক এট দিস পিকচার, সি পেপটাইডটা কোথায় তৈরি হয়েছে? কোথায় তৈরি হয়েছে? তাই তো? And this is in pancreas কোথায়? হলো এই ব্যক্তির কাছে প্যানক্রিয়াস, whoever he is, হলো এর কাছে। কেন আঁকলাম? এটা মাথায় দেওয়ার জন্য যে সি পেপটাইড বডিতে তৈরি হয়, বাইরে নয়। এটা আবার কি কথা? সবই তো বডিতে তৈরি না, ইনসুলিন দোকানে পাওয়া যায়। গট দি পয়েন্ট? কেন যাচ্ছি কোন জায়গাটায়? ইনসুলিন দোকানে কিনতে পাওয়া যায়। তার মানে সাপোজ আমি কিছু জানলাম না, তুমি এলে, আমি ব্লাড থেকে ইনসুলিন মেজার করলাম, that can be islets of Langerhans insulin, or that can be XYZ pharmacy insulin. Clear idea? So endogenous insulin na exogenous insulin, body internal insulin na external insulin na mix of it, blood e insulin test kore ami bujhte parbo na je byakti insulin neয়, a person who is taking insulin, if I check his blood for insulin level, it will show us his own insulin plus outside insulin. I won't understand how much insulin exactly his body is ready to make. But when it comes to C-peptide, the external or commercial preparation of insulin doesn't have anything like C-peptide. That is pure insulin form. So external form measure C-peptide in someone's body will understand how much insulin actually his body is making. Clear? তাহলে এখানে হচ্ছে C-peptide differentiates between endogenous insulin production and exogenous insulin production. Can come as an explain why. C-peptide differentiates between endogenous insulin production and exogenous insulin production. It's very important to quantify and classify diabetes. পরবর্তীকালে বুঝতে পারবে। C-peptide gives us the idea of endogenous insulin and exogenous insulin. মাথায় রাখবে ইনসুলিনে যেটা হয় যে A chain and B chain to know that. So these two chains are connected via disulfide bridge. These are polypeptide chains. Amino acids are there, 51 overall amino acids. Clear everybody? তো আমি যদি তোমাদেরকে একটু অ্যাপ্লাইড জিজ্ঞেস করি, ডায়াবেটিস ক ধরনের তোমরা জানো সোফার? বলো। আচ্ছা, একজন বলো ডায়াবেটিস ইনসিপিডাস, ডায়াবেটিস মেলাইটাস। ইটস কারেক্ট, আমার কোশ্চেনটার ফরমেশন ভুল ছিল, ওই জন্য তুমি ঠিকই উত্তর দিয়েছো সেই সব। ডায়াবেটিস মেলাইটাস ক টাইপের জানো? বিকজ ডায়াবেটিস ইনসিপিডাস হ্যাজ নাথিং টু ডু উইথ ইনসুলিন। একটা হচ্ছে ইনসুলিন ডিপেন্ডেন্ট, একটা হচ্ছে ইনসুলিন ইনডিপেন্ডেন্ট। ক্লিয়ার? এটা আমি আবার বলবো, জাস্ট বেসিক, এখানে ঢুকছি বলে একটু। ইনসুলিন dependent and independent, what does that mean? What is insulin dependent diabetes? হ্যাঁ, ও কারেক্ট বলেছে। ইনসুলিন ডিপেন্ডেন্ট ডায়াবেটিস মানে তোমার ব্লাডে ইনসুলিন তৈরি হওয়ার ক্যাপাসিটি কমে গেছে। Your pancreas is unable to supply insulin or create insulin. জিরো হতে পারে, কমও হতে পারে, যতটা দরকার প্যানক্রিয়াস করতে পারছে না। সো টু কিপ ইউর সুগার ইন চেক ইউ নিড এক্সটার্নাল ইনসুলিন, সো ইউ আর ডিপেন্ডেন্ট অন ইনজেকশনস। ক্লিয়ার? ইনসুলিন ডিপেন্ডেন্ট ডায়াবেটিস মেলাইটাস। ইনসুলিন ইন্ডিপেন্ডেন্ট ডায়াবেটিস মেলাইটাস, ইনসুলিনের স্ট্যাটাস বডিতে যাই হোক তোমার ডায়াবেটিস হয়েছে। করে দেখা, হ্যাঁ একজন দেখালো। So obesity is a wrong major contributor to that. So basically যেটা হচ্ছে এদের অনেক সময় strangely we can see that their insulin level is even higher. The problem is in the receptor level. Any hormone has to work through receptor. So there are insulin receptor, which is my next topic actually. That's why we are going into it like that. So any hormone has to work through receptor. If your insulin receptors are deficient or dysfunctional, or if there is insulin resistance at cellular or organ level, whatever insulin is present in your body, you will still have diabetes. So these are two different types, but that is insulin independent diabetes. সেই জন্য insulin independent diabetes we do not treat with insulin. We use something else to reduce the insulin resistance. তাদের ক্ষেত্রে ওষুধ আমরা দিই। ক্লিয়ার হয়ে গেল? সো এবারে আমরা আসছি ইনসুলিন রিসেপ্টর। সো ইনসুলিন acts through insulin receptor. You can see alpha is on the cell membrane level, that is extracellular. Alpha subunit is extracellular. Beta subunits are transcellular. Alpha subunit extracellular, beta subunit transcellular. They are connected with disulfide bridge. And attached, there are a level of small chain reactions. These reactions are usually phosphorylation. মাথায় রাখার জিনিস তাহলে কি? There is a level of phosphorylation. Beta subunit phosphorylation of intracellular part of the beta subunit, which leads to activation of number of further phosphorylating enzyme, and ultimately the beta receptor substrate. IRS is insulin. Insulin এসে insulin receptor এ লাগছে. The moment it happens, extracellularly লাগছে insulin এসে. Insulin can't go through. Insulin এসে extracellularly লাগছে. The moment insulin is attached with insulin receptor, there is autophosphorylation of beta subunit. Now beta subunit is like a plug which is transcellular, যেটা সেলের ভিতরে যাচ্ছে। যেই মোমেন্টে বিটা সাবইউনিটের অক্সোফসফোরাইলেশন হচ্ছে, মাল্টিপল সেকেন্ড লেভেল, থার্ড লেভেল অফ সেলুলার সিগন্যালিং ইজ অন। Cellular signaling on মানে most of the cases you will understand one thing, just understand one thing, if phosphate group is associated with or attached with something, it gets activated. Any inactive molecule, if phosphate group is attached, most of the cases it is activated. তাহলে যেই এখানে এটা হলো ডকিং, মানে কি নৌকো এসে তীরে লাগছে, দ্যাট ইজ ডকিং। সো ইনসুলিন রিসেপ্টর সাবস্ট্রেট গুলো এসে ইট ইজ বিটা সাবইউনিট। সো ইনসুলিন রিসেপ্টর সাবস্ট্রেট দিজ আর অ্যাক্টিভেটেড। নেক্সট যেটা হচ্ছে আফটার দিস লিডস টু অ্যাক্টিভেশন অফ phosphoinositol 3 kinase. So this is known as insulin receptor substrate. As it is activated, it activates PI3K pathway. PI3K pathway. That leads to further activation of protein B. Kinase means it will again phosphorylate. Kinase মানে কি ফসফেট যোগ করছে একটা করে ফসফোরাইলেশন করছে। Protein kinase B acts on GLUT4. Glucose transporter 4, it is insulin dependent glucose transporter. কোথায় থাকে? Skeletal muscle, adipose tissue, cardiac muscle, তিনটে জায়গাতে ইনসুলিন ডিপেন্ডেন্ট। এটা কি? ফ্যাসিলিটেটেড ডিফিউশন। গ্লুটটা কি? ফ্যাসিলিটেটেড ডিফিউশন। GLUT4, on the basis of this PKB যখন GLUT4 টাকে ফসফোরাইলেট করছে, this GLUT4 is GLUT4 was inside the cytosol, anywhere in the cytosol, under the function of PKB and further subsequent phosphorylation, GLUT4 is now activated and expressed. Ota giye express means on the cell membrane, it is over there and placed over there. O jodi cell membrane e na jay, had GLUT4 not been present in cell membrane, it will not be able to catch glucose from outside. Tale jete hobe. Tale normally ki hocche, cells are dormant, insulin eshe touch koreni. ইনসুলিনের ফাংশনটা কি? ইনসুলিন ফাংশন ইজ রিডাকশন ইন ব্লাড গ্লুকোজ। ব্লাড গ্লুকোজ যদি রিডিউস করতে হয়, দিস এক্সট্রা গ্লুকোজ ওয়্যার উইল ইট গো? ইট শুড গো ইন্ট্রাসেলুলারলি। এটা তো সবসময় মাথায় রাখতে হবে, এক্সট্রা সেলুলার থেকে ইন্ট্রাসেলুলারের মধ্যে চেঞ্জ করাচ্ছে। ইনসুলিন কিক্স এক্সট্রা গ্লুকোজ ইনটু দ্য সেল। কি করে হচ্ছে? ইট ইজ বাই ইনসুলিন ডিপেন্ডেন্ট গ্লুকোজ ট্রান্সপোর্টার। So, how is the function? Function is activation of insulin receptors in the cell membrane, leading to that's the whole pathway. Is this the only thing that insulin does? No. Insulin also helps in anabolism. Insulin is an anabolic hormone. কিভাবে কাজ করছে? The other function is this is the function at molecular level. This is the function. Multiple things I did not speak about here. There are multiple other to mone rakhte তো পিজি লেভেল এগুলো তোমাদের জাস্ট এগুলো আছে যে মানে এই যে স্টেপ, এটা সিম্পলিফাইড পিকচার। এর মধ্যে নিউমেরাস স্টেপস আছে যেগুলো উই ডিডন্ট ড্র, এন্ড নিউমেরাস স্টেপস আছে যেগুলো ইয়েট টু বি ডিসকভার্ড। এগুলো মলিকুলার লেভেলে দিস ইজ দ্য সিম্পলিফাইড পিকচার। টোটাল আইডিয়াটা হচ্ছে ইনসুলিন অ্যাক্টস থ্রু ইনসুলিন রিসেপ্টর। Insulin receptor is also like this, 2 alpha unit and 2 beta subunit. Alpha subunits are extracellular, beta subunits are transcellular. All of them are connected via disulfide bridge. So whenever some change is happening in alpha, beta is also getting the taste of it. Alpha is catching the insulin in the blood. Whenever that is happening, beta is autophosphorylated. Now since beta is autophosphorylated and it is inside the cell, now cell knows and cell got this signal ke ha insulin eshe geche, now start all the functions, all the action first switch is phosphorylation. Once that happens, this will be attached with insulin receptor substrates which is present in the cell. Now this insulin receptor substrate, depending on the cellular and extracellular demand, either will go into glucose metabolism or will go into the growth mechanism. Glucose metabolism, next step is PI3K pathway, which ultimately acts through the protein kinase B, ultimately goes to the GLUT4 expression. GLUT4 will catch sugar from outside and move sugar into inside the cell. So sugar jodi cell er moddhe dhuke jay, you will get less amount of sugar in the blood. It's always a homeostasis between blood and cell, blood and cell. GLUT4 that is usually present in the skeletal muscle, cardiac muscle, adipose tissue. Clear everybody? অন্য সাইডে কি হচ্ছে ম্যাপ কাইনেজ, দিস ইজ মাই অসুবিধা নেই, ম্যাপ কাইনেজ, দিস ইউ ক্যান রিমেম্বার, and through MAP kinase various nuclear transcription signal, transcription পরেই ট্রান্সলেশন, তারপরেই প্রোটিন সিনথেসিস, ইফ ইউ রিমেম্বার বায়োকেমিস্ট্রিতে পড়বে ট্রান্সক্রিপশন, ট্রান্সলেশন, পোস্ট ট্রান্সলেশনাল মডিফিকেশন, অ্যামিনো অ্যাসিড তৈরি হয়ে গেল, আলটিমেটলি দেয়ার উইল বি আ প্রোটিন, এন্ড ইফ দেয়ার ইজ প্রোটিন দেয়ার উইল বি গ্রোথ। একটা লোককে গ্রো আপ হতে গেলে কি করতে হবে? আরো মাসল চাই। মাসল মানে কি? দ্যাট ইজ প্রোটিন। আরো ভেসেল চাই, মাসলে নতুন ভাস্কুলার, সেগুলো কি গ্রোথ ফ্যাক্টর, দোজ আর অলসো প্রোটিন। সো বেসিক্যালি ম্যাপ কাইনেজ লাইনে এটা যেতে পারে। সো একটা কোশ্চেন আসে, ইনসুলিন ইজ অ্যান অ্যানাবলিক হরমোন। ইনসুলিন ইজ অ্যান অ্যানাবলিক হরমোন। অ্যানাবলিক মানে কি? যে গ্রোথ করছে। ক্যাটাবলিক মানে কি? যে ডিকে করছে। ক্লিয়ার এভরিবডি? ইনসুলিন ইজ অ্যান অ্যানাবলিক হরমোন। কি করে হচ্ছে? থ্রু দি ম্যাপ কাইনেজ, ইফ ইউ রিমেম্বার। ক্লিয়ার? এই জায়গাটা গেল। আজকে লাস্ট যেটা করাবো সেটা হচ্ছে দুটো রিসেপ্টর which is very important, SGLT and GLUT. এটা ডিফারেন্সটা করি, উইল বি ফিনিশিং আপ ফর টুডে। সো গ্লুকোজ চ্যানেলস এন্ড গ্লুকোজ ট্রান্সপোর্টার, তাদের কি কি বেসিক টাইপস? দেয়ার আর টু বেসিক। These are two things. One is GLUT transporter, glucose transporter, another is sodium glucose link transporter. Both of these, they do have subtypes, but right now for the simplicity we are just keeping as it is. যেরকম তারা আছে, just দুটোর মধ্যে ডিফারেন্স আমরা বলছি। So what GLUT does? GLUT is insulin and that is present in skeletal muscle and adipose tissue. Insulin is they will act, and সেটা কিভাবে? সেটা ওইভাবে। ইনসুলিন না থাকলে, ইনসুলিন এসে ইনসুলিন রিসেপ্টর, if that is not attached, GLUT will not function, GLUT4 will not function. There is insulin independent like GLUT2 which helps sugar entry into liver. It is insulin independent. ইনসুলিন না থাকলেও সুগার এন্ট্রি করাচ্ছে। সেটা কিভাবে হয়? ট্রান্সসেলুলার গ্লুকোজ গ্রেডিয়েন্ট, তার উপর বেস করে। মানে এটা যদি হেপাটোসাইট হয়, বাইরেটা যদি ব্লাড হয়, if outside we have higher glucose, inside we have lower glucose, GLUT2 will catch extra glucose from outside to inside. It doesn't require any insulin to say এই কাজ কর, no. Got it? Skeletal muscle এর ক্ষেত্রে GLUT4 কে অ্যাক্টিভেট করতে হয় এই পাথওয়েতে, GLUT2 কে ওইভাবে অ্যাক্টিভেট করতে হয় না। There is other pathway, but insulin directly is not required in case of GLUT2. Both of these are energy independent process. Energy independent process. So if it is, that means there is no function or GLUT4 function, there is no need of an ATP. Why that happens? Because this is a facilitated diffusion. Facilitated diffusion. So diffusion, a passive movement based on concentration gradient. From higher concentration to lower concentration, things are moving. But you need something, some vehicle for the movement, and that is the transporter. Facilitated diffusion. কোথায় কোথায় হচ্ছে? লিভারে হতে পারে, প্যানক্রিয়াসের বিটা সেলেও হতে পারে, হাইপোথ্যালামাসের মধ্যেও রয়েছে, গ্লুট 4টা মেজর ভাবে তোমার স্কেলিটাল মাসল অ্যান্ড এর মধ্যে রয়েছে কি বলে কার্ডিয়াক মাসল, স্কেলিটাল মাসল অ্যান্ড অ্যাডিপোজ টিস্যু। কিডনিতে আছে, ইন্টেস্টিনে আছে, মাল্টিপল এরিয়াস। উই অলসো হ্যাভ গ্লুট 5 which is fructose transporter। ওগুলো নিয়ে আমরা পরে কথা বলবো। কামিং টু দি SGLT, this এইটুকু করিয়ে we will stop today. Renal physiology is done? Not yet. Nephron, you remember? Proximal convoluted tubule, you remember? Lumen, you remember? Proximal convoluted tubular, excited lumen, the other side is renal interstitium, remember? The blood vessels are on the other side, lumen is on the other side. So all the cells, one side is urine, the other side is blood. This is simplified. Clear everybody? Huh? এইবারে চলে আসছি। So it this side is lumen, urine formation হচ্ছে, renal, so if I have to reabsorb anything from urine, the pathway will be this, correct? Clear? Urine থেকে if I have to reabsorb any substance, I have to catch it from the glomerular filtrate, I have to reabsorb through the cell, this is transcellular pathway, and then I have to kick it into the blood. এই তো clear idea. এইখানেই we are having SGLT, we are having SGLT on this side, sodium linked glucose transporter. This sodium out of the cell with respect to potassium, so we have sodium out of the cell, sodium gradient inside cell will maintain. যত সোডিয়াম এখানে কম হবে ইউরিনের তুলনায়, more and more sodium will go in, and more and more sodium will go in, simultaneously more and more glucose will go in. So this way it's a secondary active transport. There is a motor running on this side, basolateral membrane. It is creating the sodium gradient by kicking sodium out with the help of ATP breakdown. তাহলে কি হচ্ছে, more and more sodium ঢুকছে, যত সোডিয়াম বেরোচ্ছে তত গ্লুকোজ ঢুকছে। গ্লুকোজ ঢুকলেই হবে, it has to go out, otherwise the inside the cell there will be clogging. So what is happening here is transporter, that is GLUT. This is in the transcellular pathway, it is moving to the blood via GLUT2. Again insulin independent, therefore there is no need of insulin. So GLUT2 is present in liver, in pancreas, beta cell, in kidney, this way, in intestine too. তাহলে SGLT, sodium linked glucose transporter, this is the SGLT. This transports via a secondary active transport. Primary active, sodium, potassium, ATPase. Secondary active, with the help of that whichever ancillary industry is made of, that is secondary active. SGLT is the secondary active thing. Glucose ঢুকছে, and this glucose is also channelized via the next one, GLUT2 দিয়ে বেরিয়ে যাচ্ছে। Clear everybody? এইটা পরীক্ষাতে আসে, ভীষণ ইম্পর্টেন্ট। SGLT can come as a short note itself, GLUT can come as a short note itself, glucose receptors and glucose transporter এটাও short note আসে, তখন এটা লিখতে হবে। ইন্ডিভিজুয়ালি গ্লুটের অনেকগুলো ভাগ রয়েছে, সাবটাইপ, SGLTর অনেকগুলো সাবটাইপ আছে। We are not expecting as of now from you, লিখতে পারলে তো খুবই ভালো, বাট আদারওয়াইজ এইটুকু লিখে এলেই চলবে। ইনসুলিন রিসেপ্টর ইজ আ শর্ট নোট, যেটা লিখিয়ে দিয়েছি, ইউ নিড টু ডু দ্যাট। অ্যান্ড পার্টিকুলারলি কোন কোন সেল থেকে কি হরমোন বেরোচ্ছে, দ্যাট ইজ অলসো MCQ or OSPIR কোশ্চেন। আলফা বিটা গামা, আলফা বিটা ডেল্টা ডি or F সেল থেকে কি বেরোচ্ছে। Clear everybody? এখান থেকে we will be next day, we will be getting into the carbohydrate, protein, fat metabolism under insulin action, then diabetes. That's the whole thing.
So we have covered this content on the development of the GI system beforehand. Now we are moving into the urinary system development. Now as this part have got like a complex development features which is involving in the developmental process, we are splitting it down into the development of the kidney and rest part of the urinary system in the subsequent session. So briefly, we are going to talk about the development involved with the kidney. Later on, we'll talk about this particular kidney developmental error, which is important to us rather, and then we'll move to the other part of the development of the urinary system, like a bladder and this particular urethra and other system, which is a part of this excretory part. Now, the content what we are going to cover in this region is going to be simple and short. So, our point of understanding on the kidney development is that first we're going to understand this kidney have got different sources. We have learned this kidney have got two parts. We call them as excretory part and the collecting part. So, we are going to see the different parts of the kidney source from which developmental origin. Second thing, as the kidney moves over the period of time from this in utero development, it has the changes with this series of the complex nature of the kidney. So, the kidney is the only organ which keeps on updating with an advanced version as we proceed through the development. So, the different kidney system, that is going to be a topic of discussion. So, we are going to see this, how many kidneys we had eventually and what are the roles of different types of kidney in the process of development. Third thing, if you have different kidneys, then we have this particular kidneys blood sources. So, these blood sources of the kidney on the different system, that is will be coming from the different areas that we have to understand the different arterial supply of the kidney. And as we are saying that different kidneys develops from different phases of intrauterine life, we have to know where this particular different kidneys are placed. That means we call them as positions of kidney. So, these are the concerning point for us. We are going to identify this particular region of embryological developmental aspects of the kidney, and last not the least, which is related to it, is the clinical problem or error in understanding this particular kidney problem, which are basically our questions. But if you do not understand how this particular process goes or develops, we do not exactly know how this particular error have occurred and how to address those things whenever we are going to write this in exam questions. So, we start with this particular content topic and we start with the kidney development, which is we are going to talk back about this particular age of our life, which is about this particular age, third week of life. We have this mesoderm which is formed, and this particular mesoderm is split into three segments, which is close to the midline. We call them as paraxial mesoderm, which splits down into somites, small blocks, which gives rise to the vertebra. And it has a lateral end, we call them as lateral plate mesoderm, which splits into two parts, which is known as somatofluoric and splanchnopleural layers. In between it has a coelom, that's the part which is on the two extremes. In between this lateral part and this medial part, which is known as this particular intermediate or paraxial mesoderm, we have this particular in between layer which is very short. We have this layer which is present in between the lateral plate and the paraxial mesoderm. We have a small strip of this mesodermal tissue, we call them as intermediate mesoderm. Now, we know this particular intermediate mesoderm, it's there, and from this intermediate mesoderm, this kidney develops. So, this is the oldest form of this particular knowledge of this mesodermal origin, where from this kidney develops. It's mesodermal in origin, and it is an intermediate part. So, the intermediate mesoderm from where we see this kidney developing, that's the basic thing. Now, out of this particular intermediate mesoderm, which is a mesodermal tissue, we see about third week of life, an elevation or a bulge comes out. So there's a bulging which pops up at the age of 3 weeks of life into this particular paraxial mesoderm. That particular popped up part we call them as urogenital ridge. So this mesoderm intermediate at the 3rd week of life shows an elevation, we call them as urogenital ridge. Now if you split this particular term as urogenital unit, it gets the two names, that's the urinary system and the genitourinary system. So this form develops into two parts from this urogenital ridge. A part develops into a ridge, we call them as nephrogenic cord. It develops into urinary system, the kidney system. And the other part, we call them as gonadal ridge. So this particular gonadal ridge forms the genitalia. That means testicles, that means ovary, and that means the collecting system which is present in it. So this is the oldest form of the developmental source of the kidney, mesoderm, intermediate mesoderm, and the bulge which is known as urogenital ridge, and the urogenital ridge divides into two parts with this particular or transforms into two parts. One is known as nephrogenic cord. Now this particular nephrogenic cord is the old source of the kidney system. So we stop at this particular point and just like go elaborating about this particular element, we call them as nephrogenic cord. Now we have to see what is nephrogenic cord. So this particular nephrogenic cord, which is a kind of throughout the length of this developing embryo, we see a bulge coming out. So it is coming, extending from this neck region of this developing embryo and ending to the sacral region, a bulge coming over here which is known as nephrogenic cord. Now this particular nephrogenic cord, you can see this particular region or the mass of the tissue which is involving in this region, which is present on here, we call this as a nephrogenic cord. It is extending from the neck region to the sacrum. So this particular nephrogenic cord eventually develops into different forms or different phases of the kidney system. Okay? So this particular element which is known as the bulge, that particular bulge we call them as nephrogenic cord. So this particular nephrogenic cord is the oldest form of the kidney tissues where from this particular embryonic kidney have developed from. So this is what we carry this much. Now during the process as we have seen that whenever we have going to discuss about any organ to develop, we see that's the only single organ we have developed with, gut tube, the liver, the gallbladder, any organ, we have a single organ which transforms and grows. Now kidney is the only organ which keeps on updating as the time progresses. We get a newer, better version of kidney as we progress through. So we have three phases of kidney development as we are going in utero life. The oldest form, primitive form, the intermediate form and the adult form are the best version we have. So we have three kidney to develop, and the three kidney we develop which is from the tissue which is known as nephrogenic cord, we call them as, on the top we see that there is a tissue, we call them as pronephros or nephric kidney. This is the oldest form. Then we get the second version, advanced version from the pro, we get this form, we call them as mesonephric kidney. And then we get the adult version which is we have the highest end of this, we call this as metanephric kidney. So we get the three updated version till we receive the most advanced version of the kidney system. So we start with this oldest form, we call them as pronephric kidney. Then we have this mesonephric and this metanephric. And these particular kidneys, as we get this particular advanced version with progression of the time, develops in different region of this developing embryo. If you see this particular embryo, this is the head end, this is the tail end, this region we call them as neck end. This oldest form of the kidney develops in this region, we call them a cervical region. So this particular pronephric kidney, which is the kidney number 1, we had developed in this region, we call this as a cervical region, we call them a cervical kidney. So this particular oldest form of the kidney, pronephric kidney, is non-functional. It yet to function, but it is discarded afterwards. So it appears to disappear. So whenever we talk about the kidney, we see that the kidney had two systems. So we call this kidney system as excretory system and a collecting system. So that means something is manufacturing the urine, which is the excretory unit, and then once this urine is produced, it is collected and reserved to a part. We call them as collecting system. So we have this kidney has two basic fundamental parts. We call these parts as and then we have this collecting part. Now this particular element which is involving this particular thing, we call them as excretory part, that is involved in the production of the urine. And then we have this collecting part which is collecting the urine whichever it is produced. Now this particular excretory part of this particular oldest form of the kidney, which is known as pronephric kidney, disappears, and then we are left with this collecting part of the kidney. So this particular collecting part of the kidney system prevails. So we get this particular elements of the kidney which is having this pronephros or pronephric kidney. The pronephric kidney, if you split this particular kidney tissues, it has two parts, excretory part. So excretory part of this pronephric kidney completely gets destroyed. But this collecting part of this particular pronephric kidney remains. And this particular collecting part, we call them as nephric duct. We call them as nephric duct. So this particular nephric duct part remains. So this nephric duct which remains gets utilized by the second kidney. So we have this first kidney, then we get the second kidney and the third kidney with time. So the first kidney we get at the 3 weeks of life, it fails to function, it is been utilized or replaced by the second kidney or advanced kidney, we call them as mesokidney. So this mesokidney also had these two parts, the excretory part and the collecting part. The excretory part which is producing the urine, it develops, but it utilized the collecting part or the nephric duct from the previous kidney and uses that. So this is how this particular kidney utilizes this particular part. Now if you see this particular picture, we have this particular nephrogenic tissue, and behind this nephrogenic tissue we have a tube-like structure running on the back side. So this particular tube-like thing which you are seeing here is that particular thing, we call that as mesonephric duct, also known as this nephric duct. That is what we are focusing here. So this particular nephric duct is the collecting system. So whatever the urine is produced from this kidney is joined with this particular tubules through this particular duct system, the collecting duct system, which is known as the nephric tubules, mesonephric tubules or nephric tubules, and this particular mesonephric tubules goes eventually to this particular part which is known as cloaca, the lower part, and drains into. So this is what we collect at this particular point as a collecting part of this particular pronephric kidney, which remains here and utilized by this mesonephric kidney. So the mesonephric kidney, which is developed in this region, which you are seeing here in the second phase, in this region which is called as thoracic region. So the second kidney we develop at the thoracic region. The second kidney functions briefly, doesn't function too long, maybe just like a 3 weeks. So this particular 3 weeks, this particular second kidney functions. So this mesonephric kidney only works for 3 weeks. That means up to 6 weeks, we have this particular mesonephric kidney working. And then we see that the 6 weeks and beyond, basically end of 5th week, but we can take it as 6 week and beyond, we get this most advanced versions of the kidney, which is the adult kidney. We call them as metanephric kidney. So this is how the kidney gets this newer or advanced version and gets this particular thing functional. So pronephros, which develops in the cervical region, then we have the mesonephros, gets into this thoracic region, and then we get this most advanced version, which is the kidney. We call those metanephric kidney. We will talk about the metanephric kidney, the detail of it in the subsequent parts. So this is what we are talking about, the development of the kidney. So we start with the pronephros, which develops here, disintegrate. The tube part, however, is utilized by the next form of the kidney, which is this mesonephric kidney. The mesonephric kidney works for roughly 3 weeks, then it degenerates and replaced by the third form, which is known as the metanephric kidney. That's the adult kidney, whatever we get here. So this is the most advanced kidney versions we have here. So we have to know this particular, how this particular kidney, which is the metanephric kidney, is developed from or developed into. So talking about this particular kidney development over the period, we won't know. So this is what we have to talk about, the little detail about the development or the functional component of this adult kidney, which is known as the metanephric kidney. As we have mentioned, this particular metanephric kidney or any form of kidney has got two systems. The two system which is existing in it is divided into two parts. We call them as collecting duct system and the excretory system. Adult kidney develops from a different source and the secretory part develops from a different source. The excretory part develops from a source, we call the same thing, which is known as nephrogenic tissue. That means it is developing from the mesodermal element, which is coming in the paraxial mesoderm. This collecting system develops from a source, we call them as ureteric bud. So we have these two things coming from two different sources. So this is what we have to understand, this is what we have to know related to this particular development of this kidney from the two sources. Now, looking at the bottom side picture, as you can see, this particular adult kidney develops from this particular tissue, we call them as metanephros, which is lying here in the form of developing over here in this bottom side. So this region, this kidney develops from the adult kidney, which is going to be developed, is developing on the region called the sacral region. Kidney sets to develop at the beginning on the region of this abdomen is on the sacral region. That means in the pelvic cavity, this particular adult kidney is developing. Whereas we see this particular oldest form of the kidney developing in the neck region, developing in the thorax region. The adult kidney, which is the adult form, which is known as the metanephric kidney, develops in the region which is known as sacral region. Now into this particular sacral region, once this particular kidney develops, it develops from two sources. So this particular nephric tube which is there has an out pouch. So this particular region on the sacrum develops from this nephric tube, which is a drainage tube, develops as an out pouch. We call them as ureteric bud. So we have a picture which will be showing soon about this particular nephric tissue. So we have this particular tissue which is developing from different sources. So these pro, meso and the meta tissues are coming. We have the connecting tube which is known as nephric tube running there. So from this particular nephric tube which you seeing here, an out pouch like this grows into this nephrogenic tissue. So this particular out pouch we call them as ureteric bud. So this particular ureteric bud is visible on this particular bottom picture as you can see. So this is the beginning phase. You see that this is the nephric tissue or nephric bud, which is nephric tube which is present in as a tube form, and this is a nephrogenic tissue which is going into this particular secretory form or excretory part of this particular kidney. Now you see this from the tube there is an out pouch like this which is known as ureteric bud. So this particular ureteric bud which is an out pouch from this nephric tube grows into the developing nephric tissue which is going to be the adult form of the kidney. Now this particular ureteric bud which grows into this particular metanephric tissues and eventually develops into. So this particular part which is known as the ureteric bud, as you can see, this ureteric bud initially encroaches into this metanephric kidney or metanephric tissue like this, grows like a bulge. So this ureteric bud grows into metanephric tissue and splits down into these smaller branches. As this time progresses, you see that the smaller branches grows deeper into this developing kidney tissue and forms into the system which is known as the collecting duct system. So from here, this ureteric bud grows into this metanephric tissue, splits down into branches and forms this particular ureter or renal pelvis. Then you see that grows into this minor calis, goes into major calis like major calis, then in minor calis, and then into this particular collecting ducts. So from this ureteric bud, you see that which is developing from this particular out pouch which grows into the nephrogenic tissues, grows into this particular collecting duct system. Contrary to this, as this particular ureteric bud grows into this particular metanephric tissue or metanephric area, there is an collections of this particular metanephric tissue goes in a circular formation. We call them as metanephric vesicles. Now these metanephric vesicles unites with the developing ureteric bud and joins and forms a pear-shaped structure and eventually forms this S-shaped structure which again goes on the coiling subsequently and forms this particular complex tube system which is this particular excretory part of the kidney develops like a Bowman's capsule, primary convoluted tubules, your loop of Henle and distal convoluted tubules and eventually drains into the collecting duct system. So you see that the kidney, as you see that we divide into the developmentally the functional part of the kidney and this development part of the kidney into two parts. The excretory or secretory part of the kidney which is developing from these nephrogenic tissues like transforms into, and the collecting system which develops from the ureteric bud which grows down or breaks down into minor calis, major calis, like all this collecting system. Eventually the collecting system develops into and joins together and makes the whole thing. And slowly the blood vessel grows into this Bowman's capsule, forms the trough which is coming from the branch of distal dorsal aorta and forms this collection, we call them as glomerulus. And as the blood flows through, the filtration happens and this urine is excreted and which is collected through it and develops into this particular tube system and grows into this particular collecting system to this particular reservoir system which is into this urinary bladder. So as you see, this particular kidney develops from two different sources. One is from this particular nephrogenic tissue and another is from the ureteric bud tissue. The interactions of these two elements is essential to have to grow into a proper kidney, nephrons or the Bowman's capsule and everything together. So if you have a wrong interaction of these nephric tissue with this particular ureteric tissue or ureteric bud tissue, if it goes something wrong, we develops a faulty kidney system or get this particular kidney which is ill formed. So this is how the adult kidney is formed. So to summarize the thing about the kidney development, we get these three forms of the kidney, pronephros, then we get this particular pronephros formed in the future neck region, we call them a cervical region, which do not have a proper functional, which mostly get destroyed. The collecting duct, which is known as nephric duct, remains there, most of the kidney is destroyed. Then we get this next form, which is known as mesonephric kidney. It functions for these particular 3 weeks of life. It develops into the future thorax region, and that particular kidney is eventually replaced by another form, which is known as metanephric kidney, which is the adult kidney we have. The adult kidney to set to develop in the region, we call them as pelvic region or sacral region. So this particular kidney in the adult, which develops in the sacral region, sourced from two regions. One is coming from this particular nephrogenic cord, which transforms into this collecting system, transforms into this like a excretory system, and other form which is developing from the ureteric bud, which forms a collecting system. This collecting system with this excretory system unites and eventually gets this particular thing completely developed. So if you have this particular metanephric vesicles and this ureteric bud fails to interact properly, we have a problem of the whole kidney development. So which is kind of like a point of concern to us. So this is how this kidney system developing from the different region in the different phase of life. Now, point of concern for us is that the clinical aspects of the kidney developmental error. So this is a summary of the thing. So we have this kidney source from two areas, ureteric bud and this metanephric kidney. The metanephric kidney forms the Bowman's capsule, primary loop, primary convoluted tubules, loop of Henry, distal convoluted tubules, junctional tubules, which eventually drains into the collecting tubules, then calyces, minor calyce, major calyce, renal pelvis and ureter, which forms into it complete system. So if this ureteric bud and the nephrogenic tissue fails to interact properly, we have an error which we are going to talk about very soon. So this is the whole summary of the thing about this adult kidney formation. Now, about the error of the system, of this kidney developmental error, which is concerned to us. Now we see that when we see that kidney develop in the adult form, which is known as the metanephric kidney, develops in the region, which is the primitive region. This is in the pelvic region, it sets in. Now what we see here, this particular kidney is placed under the diaphragm. So this kidney, which was initially developed in this sacral region, has to move up during the process of development. So this particular movement of the kidney from the sacral region to this under the diaphragm, the position finally it gets, we call them as ascent of kidney. So this particular ascent of the kidney, which is an important phenomenon. So when the kidney develops, which is about the 5 week of life, the final positions of the kidney, which is under the diaphragm, is about the 10 week of life. So from the 5 week of life to the 10 week of life, the kidney moves up or climbs up from the sacral position to the under the diaphragm position. So this particular ascent of the kidney is an important phenomenon. So the kidney rises from the sacral or the pelvic cavity to under the diaphragm. So as the kidney moves up, there are some factors which is triggering the kidney to move up. So what are the factors which moves up or which lets the kidney to move up? Now first factor which helps this particular kidney to move up from the bottom to up is that the lumbar region and the sacral region of the embryo grows differentially, grows more. As a result, this particular lower part of the body is elongated. As this particular lower part of the body is elongated, we get more room and kidney moves up. This is one factor which is helping this particular kidney to move up. Second factor is that the blood sources which the kidney initially had at the lower point dries up, which gets less blood. Now, as you can know, as you do know, about kidney is a highly vascular organ because it has to get this large artery to feed it, to filter the blood. So it needs a wider caliber of the blood vessel which is present up this region on this close to the abdominal aorta. So for the sources of the arterial region, which is requires more blood through the kidney gradually moves up to the apice region close to this particular diaphragm. So these are the factors which helps us along with this particular curvature which helps to this particular kidney to move up. So as this particular kidney moves up from this region, it takes the regional or segmental arteries. So when the kidney is at the bottom, it receives the blood supply from these arteries which is known as the common iliac arteries. As it moves up in the lumbar region, it takes the blood arterial sources from here, we call them as lumbar arteries. Then eventually it reaches to this particular under the diaphragm, it takes the blood directly from this particular abdominal aorta as renal arteries. So as this particular kidney moves up from its sacral position to this particular lumbar position and eventually to the pre-diaphragm or under diaphragm region, it gets different arterial sources and get different positions. So this rise of the kidney is known as ascent of the kidney. So rise of the kidney is coming as a short note frequently. You have to narrate it, the time frame when from this kidney starts it coming up from the bottom to the up, and what are the factors that is triggering the ascent of the kidney which is moving up from the sacral region to this under the diaphragm region. Now, if this particular kidney when it is moving up, if it is arrested at any point, we get the abnormal positions of the kidney. So the abnormal positions of the kidney are likely to be found in the pelvic region if it is not risen at all. So we may get this kidney placed in this iliac fossas, that is a possibility. It could be present in the lumbar region. If it had climbed little bit, it can go down into the lower part of the abdomen in lumbar region. We call them as a lumbar kidney. And if it is present at the normal position, we call them as normal positions of the kidney. This is one thing. Next thing, as the kidney moves up, ascends up from the sacral position, it makes a rotation reaching at the final point. So initially, the hilum of the kidney is directed forwards. So the kidney, you have seen that the hilum through which the blood vessel goes. So initially, the kidney hilum was facing forward. As the kidney moves up and reaches to this under diaphragm region, it makes a 90-degree medial rotation. And with this 90-degree medial rotation, at its final point, the hilum is directed towards the midline or medially directed. So this hilum direction movement, which is our medial rotations 90-degree, happens with the ascent of the kidney to the final positions, and this particular final kidney rotation is included in the whole phenomenon whenever you are going to explain about the ascent of the kidney. So, ascent of the kidney, what is the triggering factor, what are the blood vessels it is accompanying or getting in as the kidney is moving up, and the kidney we are referring here, the final phase of the kidney which is the metanephric kidney, which is climbing up and getting into this below this particular diaphragm till it reaches to the suprarenal gland and settles down there. So this thing comes as a short note as an ascent of the kidney or error of the ascents of the kidney, which is a clinical problem. We see that. Now this is a phenomenon, as you can see, this particular A picture, B picture, C picture. You see the positions of the kidney. This particular thing from the sacral position moves up at this particular embryo, which grows or elongates in the lower or sacrolambar region. It elongates, and this kidney moving up along with this getting the richer and wider caliber blood vessels to the higher positions. Now, coming to this particular point of the blood supply of the kidney, as I mentioned, this kidney is placed in the lumbar region, kidney was placed initially in the sacral region. When it was in the sacral region, it was receiving the blood supply which is known as external iliac, internal iliac or iliac arterial as a blood sources. So, common iliac artery was the initial blood supply which was providing to the kidney. Then it moves to the lumbar region, we call them as lumbar arteries or lateral sacral arteries which were providing the blood supply to it. Then it gets to this particular abdomen, then inside the abdomen you get this particular abdominal aorta renal artery giving the blood supply. Now what happens to the arteries which was initially providing the blood supply to the kidney when it was below? The artery which was initially providing this particular blood supply to kidney, say for example this particular sacral region or lumbar region, this artery should be regressed. Now if it fails to regress, it remains as an accessory arteries or accessory renal arteries. We call these accessory renal arteries as aberrant renal arteries, which could be a trouble. That we are going to mention that what trouble it makes. So this is the blood source of the kidney at the different level. Sacral level, lumbar region, and this final pre-diaphragm or under diaphragm or sub-diaphragm region blood supply. So coming to this error of this development of the kidney, we may have the absence of the kidney agenesis, maybe bi-side or both side kidney agenesis is there. The patient is not going to survive if you have both kidney absorbed. So if it is a one kidney, we can function. If it is functioning well, we can survive with one kidney, or unilateral kidney agenesis, which is quite common. So this particular kidney which is developing from this particular nephrogenic cord, that particular nephrogenic cord may not have developed, and this particular kidney on that particular side may not have developed. That lead to the agenesis or not development of the kidney. Now, second form is this particular kidney, we call them as abnormal positions of the kidney. As I have mentioned, it could be inside this particular pelvic cavity because it hasn't moved up, we call them as pelvic kidney. Maybe both of them present inside this particular iliac fossa, we call them as pelvic kidney or bilateral pelvic kidney. One kidney had moved up and one kidney remained in the pelvic region. We call them as unilateral pelvic kidney, depending on. If the kidney remained in the intermediate positions in the lumbar region, we call them as lumbar kidney or low-lying kidney if it is there. So this particular low-lying kidney may be there in this particular position. That is another phenomenon. Out of this particular kidney error of the development, we see there is another grave thing can happen. Sometimes we see that the nephrogenic tissue lying at the bottom of this particular sacral region remains joined, and as a result of this nephrogenic kidney or nephrogenic tissue, if it is joined on the right side and left side, the lower pole of the right kidney and lower pole of the left kidney may remain united. So this particular kidney, if the lower pole of the kidney, if it remains united like this, when this particular kidney climbs up or moves up, it gets arrested. Why it gets arrested? We have this ventral branch of the abdominal aorta, like celiac trunk, superior mesenteric artery, inferior mesenteric artery. Now as you can see, this particular kidney, which you can see the lower pole is united. Now this particular lower pole of the united kidney looks like a U-shaped structure. So this particular kidney which has a lower pole united, we call them as horseshoe kidney. So this looks like a horseshoe shaped, that's why you call them as horseshoe shaped kidney. Now the trouble of this horseshoe shaped kidney is that it do not have any functional problem unless until it gets arrested when it climbs up. As we mentioned, this particular horseshoe kidney, lower pole of the kidney remain united in the sacral region and it climbs up to this under the diaphragm region. So when this particular horseshoe or lower pole united kidney climbs up, it can get arrested by this ventral branch of abdominal aorta. The earliest ventral branch of abdominal aorta is inferior mesenteric artery. It cannot cross over this inferior mesenteric artery. So as a result of this horseshoe kidney, as it climbs up, you can see this, it can be arrested at this under to this lower pole of the inferior mesenteric artery and get stunted at that particular point. And at this particular kidney, where this particular lower pole is united, the ureter, as it coming down, it may be bent. If it is bending and that remains as a kinked ureter, the urine cannot flow through, it can regurgitate back and flow back to the kidney and can destroy this particular kidney. So this particular phenomenon, we call them as horseshoe shaped kidney. Again, this is a very important short note about horseshoe shaped kidney. So you have to explain embryologically what is a horseshoe shaped kidney, why there is a horseshoe shaped kidney. Horseshoe shaped kidney cannot reach to the under diaphragm region because of this arrest of this inferior mesenteric artery holding it. And what is the fate of this particular thing if it is arrested at this point and the ureter is obstructed, resultant effect of that. So this horseshoe-shaped kidney is an important short note. Embryologically, you have to explain to it. Other thing is that you may have an additional kidney because maybe the nephrogenic tissue may be doubled up, that may leads to this particular accessory kidneys like this. The kidney may be just like have an abnormal union. It may look like sigmoid shaped. We call them a sigmoid kidney. And this particular horseshoe shaped kidney out of these abnormal positions is the important kidney positions that you have to prepare for your exam short notes. So this is what we have to know about these abnormal positions of the kidney, emphasizing on the horseshoe shaped kidney, preparing it as an exam short note. Now coming through another aspects of this thing about the kidney error, which is the last form of the kidney developmental error that we are going to talk today. So we mentioned that the kidney have the two functional elements. One is the collecting system, other is the excretory system. The collecting system develops from the ureteric bud, the excretory system develops from the nephrogenic tissue. And these two tissues interact with each other, grows into and forms this entire nephron collecting system together. Now, by any chance, by any error, if this union or the interactions of this ureteric bud with this nephrogenic tissue fails to occur, so that what happens, the excretory unit, it's not united with the collection system. So this is what we are seeing here. The ureteric bud forms this collecting system, the nephrogenic tissue forms this particular, the excretory system. Now nephrogenic tissues eventually joins with this ureteric tissue, so the urine is produced by this glomerulus, drained into the collecting system, minor calis, major calis, and drained out. So what happens in some region, if these interactions between these two tissues are failed, then the urine, whatever it is produced, may remain or may stuck within this kidney and not communicated with this collecting system. So the collecting system is not receiving any urine. So the urine, whatever is produced within this kidney, remains within this kidney, not thrown out into this particular minor calis, major calis, or the pelvis or the ureter system. So the urine which is stuck inside this kidney remains inside, remains as a pouch, as a small vesicle pouch. And there is a multiple vesicle pouch remains in the kidney, then the kidney looks like cystic kidney. And those kidney, we call them as polycystic kidney. That polycystic kidney is an error which developmentally can happen because of the faulty interactions of the nephrogenic tissue with the ureteric bud. The urine is never excreted out of the kidney, it remains in here. So this is a picture or cross section, pathological picture you are seeing here. You see this is a pouch, small pouch, which is look like a vesicle, which is remain here. So this is the excretory unit of the kidney, which is particular glomerular capsules, the collecting PCT, DCT, which are present. And this particular excretory system is not united with the calicial system. So this union is not there. As a result, urine is occupied within this particular kidney itself. And this particular kidney looks like cystic kidney. We call them as congenital polycystic kidney. So it's happened because of the failure of union of the excretory unit, that means the nephrogenic tissue, and this excretory part, that is the ureteric bud part, and on a developing kidney, and this particular kidney is destroyed on its own because of the collections of these urine within this kidney. So this is a kind of grave problem. We cannot save the kidney whatever the way we do here, unless we replace the kidney with a replacement. So this is one of the things that we have to know about this abnormal union or non-interaction error of this nephrogenic tissue with this ureteric bud, which is known as polycystic kidney. This is a grave phenomenon of a kidney error that can happen. So we are stopping at this particular point about this particular kidney development. We are not going to talk any further detail. So we are summarizing the thing, whatever we learned so far about the three kidney we had, which gets the advanced version. The oldest kidney was developed in the neck region. We call them as pronephric kidney. Then we get the next version which develops in the thorax region, which is known as the mesonephric kidney. The pronephric kidney fails to work any function. It appears to disappear. It was non-functional. Next kidney we had was functional for 3 weeks. Then we get the adult version which remains with us for the rest part of the life. The adult kidney develops in the lumbar, in the sacral region, and it climbs up. At this we develop with the time into the under the diaphragm. We call them as ascent of the kidney, which happens or triggered by the development of this body cavity along with this particular lumbar and the sacral growth. That's what this moves this kidney up and gets a better blood supply in the higher part of this particular close to the abdominal aorta. So this kidney as it moves up receives the blood supply where it was placed. Initially it was the sacral region, it was receiving the blood source from the iliac arteries. If it has stayed in the lumbar region, it was receiving the blood from the lumbar blood vessels. Then it gets the renal artery getting under this diaphragm. Now, this particular artery from the earlier sources of this kidney where it was developing from should be absorbed completely. If it remains, we call them as aberrant renal arteries or abnormal renal arteries, which is a trouble like accessory renal arteries. It may be just like a present in this particular region. So you see the lumbar artery giving a source or arterial source to the lower pole of the kidney. So this kind of abnormal renal artery is a trouble for us if it is present during surgery. So you have to be careful about this particular kidney surgery. Whenever you're doing, screen it properly with this particular vasculature in this particular renal artery. And again, if these arteries are pressing on this ureter, the ureter may be compressed as well, leading to this regurgitation as well. So this is a phenomenon. We are not emphasizing on it about this abnormal renal arteries which is present or accessory renal arteries like this. But these are the phenomena which are unabsorbed arterial sources the kidney had in the earlier phase of life. Then we have these particular positions of the kidney. Once it settles down under the diaphragm, it goes on a rotation medially. So that's an important part of the ascent of the kidney. Once it goes to the under this diaphragm till it touches this adrenal gland, then this initially the hilum was facing forwards, then it rotates medially 90 degrees to come into this hilum goes on medial direction. That's the part which we forget about talking about the kidney ascent. And then we have this particular abnormal arterial sources and this horseshoe kidney, which is an important phenomenon we talked here, which has the lower pole of the kidney united and stuck under this particular inferior mesenteric blood vessel. And this particular kidney can perform perfectly well unless if it is ureter which gets compressed over this particular inferior mesenteric artery or any other sources, then we have a trouble. Otherwise, the horseshoe-shaped kidney have no trouble with. And then we may get abnormal positions of the kidney like depending on the positions like lumbar kidney or this iliac kidney or sacral kidney, etc., etc. So these are the different forms. And that one developmental error, if we have a non-union or non-interaction properly between this excretory part with this collecting part, we may have the urine stuck within this particular kidney tissue itself or kidney parenchyma itself as a circular or as a C that like as a cystic structure. This particular cystic structure is known as congenital polycystic kidney. So where the kidney is producing the urine, but it's not thrown out to the collecting system. It remains within this kidney. So all this vesicle which you're seeing here is filled up with the clear fluid or the urine. So this is about this particular symptoms related to this particular kidney development and kidney developmental error. So that is for now today. Have any doubt, questions? If not, we can just like conclude over here. Prepare this particular clinical error like a polycystic kidney, the horseshoe-shaped kidney, the ascent of the kidney very carefully and prepare that very well. So that is all for the day. Thank you.
Now today we are going to discuss another important practical and the aim of the practical. That is very important. Last time we will ask to you the question, what is the aim of the practical? What is aim of the practical? But you don't write anything, you don't know about the aim. So if you know the aim, you know the concept, what you are going to do. Okay? So today's aim is quantitative estimation of blood urea, quantitative estimation of blood urea. Okay, I am not mentioning here the method. You just understand this is your first heading. Okay, this is the main heading. After then, next heading will become, okay, so quantitative estimation of blood urea. Okay, you know the urea. What is urea? You know urea? Okay, what is urea? What is the molecular formula of urea? First, you think that urea is a metabolic waste product of protein metabolism. Protein metabolism. How it is come? It is come by the urea cycle. Urea cycle, you know, ornithine cycle. This is will happen in the liver. Okay. So the excretion of urea, the level of the urea is totally depend on what? Protein intake. If we take the protein in high amount in our diet, the level of the protein is increases. If we take the protein low level, then the value of the urea become less. The value of the blood urea level become less. But normally urea is excreted in the urine also. It is also excreted in the urine in normal. Okay. So write it introduction first. Write it. Urea is the main end product of protein metabolism. Urea is the main end product of protein metabolism. End product of protein metabolism, and the level of urea is depend upon the diet source of the protein. Depend upon the diet source of protein. Depend upon the diet source of protein. Okay. And इसमें ये लिखो, urea is important to assess the function of the kidney. Urea is important to assess the function of the kidney. To assess the function of the kidney by checking urea creatinine level, by checking urea create ratio or urea create ratio, by checking urea create ratio. Urea create ratio. Okay. Creatinine, create, C-R-E-A-T, create, urea create ratio. Okay. Now the second heading is methods. Second heading is method. The first one is enzymatic method, same as enzymatic method, same as blood glucose. Blood glucose में भी था ना enzymatic, non-enzymatic. It is also वही paper पलटने लगे. You know there is also difference of the method between blood glucose also. It is enzymatic and non-enzymatic method. The first method is urease nasalization method. Second one is birth load reaction. Birth load reactions. We also call this method Nestler's method. Nestler's method. So we have, okay, so that we have two types of method. The first one is enzymatic method and second type is non-enzymatic method. Which one? Non-enzymatic method. Non-enzymatic method. In a non-enzymatic method, there is a one method, we call this method as DEM method. DEM stands for diacetyl monoxide. DEM method. Diacetyl monoxide. Okay. This is non-enzymatic method for the quantitative estimation of blood urea. DEM's method. Which one is first method? Enzymatic method, that is urease neutralization method. Second one is birth load reaction. Non-enzymatic method is DEM's method. So generally, which method we use to quantification of urea? DEM's method. We use DEM's method for the performance to know the level of the urea in the blood. Okay? All of you write it? Okay. Now make another heading, quantitative estimation of blood urea by DEM's method. Make another heading, quantitative estimation of blood urea by DEM's method. Okay? Quantitative estimation of blood urea by DEM's method. Makes another heading. The first heading is quantitative estimation of blood urea. Second heading is quantitative estimation of blood urea by DEM's method. By DEM's method. Nestler's reaction, Nestler's method. Now student, which thing is important? Now write down the principle. Write down the principle. What is the principle of DEM's method? When diacetyl monoxide, write down bracket DEM's, is treated in acidic medium, it decomposes into diacetyl and monoxide. Diacetyl and monoxide. That is the first step of the principle. That when you treated the DEM's in alkaline medium, it can split into two molecules. That is diacetyl. Second one is monoxide. Okay. अब इसमें लिखिए when monoxide, not when diacetyl react with urea, it forms diazine oblique diacetyl urease complex. It forms diazine और diacetyl urease complex. ब्रैकेट में लिखिएगा इसमें Pink color complex. Don't write it red. You will write here pink color complex. Pink color. Pink color. So this is the basic principle of your test. When diacetyl is treated in alkaline medium, it forms diacetyl and monoxide. Okay. And when this diacetyl is separately react with urea, it forms diacetyl urease complex or diazine complex, which is red color compound. Okay. With the intensity of this pink color, we measure the quantity of the urea. Why which instrument we use? Very good. It is colorimeter or calorimeter? What is calorimeter? Huh? तो बोलो हाँ both the terms are different, don't confuse it. Calorie. Okay. So this is the principle. Now write down the reaction of this principle, which is also very important. Which is very important. Don't talk. This is NOH. What is this is the structure of dam. Okay. When dam react in acidic medium, it is now converted into diacetyl CH3CH3. This is called diacetyl plus it is called monoxide. Okay. So when this diacetyl react with urea, so there is separately oxygen hydrogen molecule is separated from this, and this is the urea react with diacetyl monoxide. According to the second step, it forms diazine complex. This is called pink color complex. स्टूडेंट देखो आवाज नहीं आनी चाहिए. अरे CH2 वो छोड़ो सब, वो करते रहना अपनी कॉपी में जो करना करेक्शन. CH2 होगा, CH होगा. आई डोंट राइट वैलेंसी और ये सब, बस ये नोट कर लो. बाकी का ये है कि तुम लोग करते रहना अगर करेक्शन इसमें नीड है. डिस्कस करो बैठ के आराम से. आई डोंट केयर. दिस इज डाइएसिटाइल यूरियस कॉम्प्लेक्स. डाइएसिटाइल यूरियस कॉम्प्लेक्स. कौन माता बच्ची करे इसमें. Okay, so this is the first step of your principle. When diacetyl monoxide treated in acidic medium, how can you change the medium to acidic? How can you change the medium to acidic? Very good. But what you add? In the creatinine, you can change the medium to alkaline medium. How will you change the medium? In creatinine, practical? You tell? You don't know? Huh? You don't remember. There is nothing to remember. You just think how you change the medium. There are basically two types of solution we have, either alkaline or acidic. Which one is alkaline? Which one is alkaline? Ammonium sulfate, sodium hydroxide. This is alkaline medium. If we have to talk about acidic medium, it is HCl, sulfuric acid, glacial acetic acid. All these are the chemicals through which we can change the medium. So how can you remember? I don't remember. What do you want to remember? This is general concept, madam. If you don't know how will you change the medium, it is not possible to discuss about this principle. Generally, we change the medium to the acidic medium by adding HCl. Okay, we got pink color complex. With the intensity of this color, we can calculate the concentration of urea in the blood sample. Okay, now write it, the reagents which is required for this test. Reagent. The first reagent is ferric chloride. Yes, ferric chloride. What is the chemical formula of ferric chloride? FeCl3. Second one is thiosemicarbazide. Thiosemicarbazide. Write it here like that. Thiosemicarbazide. Okay. Third is blood urea standard solution. Blood urea standard solution. Blood urea standard solution. What is the meaning of standard solution? No, I am not asking you. You tell. तुम्हें concentration. We know the concentration of any solution is called standard solution. Okay, blood urea standard solution. And don't talk. Last one. Last one is क्या हो गया? ब्लड यूरिया स्टैंडर्ड हो गया, फेरिक क्लोराइड हो गया, आपका थायोसेमिकार्बाजाइड हो गया, एंड ठीक है, चलो ये रिएजेंट्स हो गए सारे. नाउ वी डिस्कस अबाउट द प्रोसीजर. So the procedure is same as all the procedure. The procedure is same as all the procedure, but here we can change the reagent. Let me discuss. This is called reagents. This is, write it in your language first. First you write, take 3 test tubes and mark them as a test blank and standard. I always tell you, you kept in your mind what is the principle. Okay, so kept in your mind, that is reagent, test, blank and standard. Test, blank and standard. First we take test, blank and standard. Okay, mark. We take 3 test tubes and mark them as a test, blank and standard. Then you draw the table. First we take our test solution. Test sample is blood. But student, you think that what we are going to develop. Listen, what we are going to develop. we are going to develop a pink color by the reaction. This is our aim, that if the pink color complex is developed, we can get the fixed value of the blood urea. Okay? But what we have in the blood? We have hemoglobin, which is red color. If we directly put the blood sample in our test solution, what happens? The pink color may hamper. We didn't get a fixed value of the urea. So what we do? Firstly, we separate out the hemoglobin. First, we separate out all the protein part of the blood and we get only the plasma. So how can we separate out the proteins from the blood? Yes? No. No. It is not a separate out process. We use tungstic acid, phosphotungstic acid chemicals. We add it and after then all the red color and red cells become settled down and we filtered out these solutions and we get the supernatant solution, clearless solution, which called this plasma. No, anticoagulant we don't use it. If anticoagulants, what we need anticoagulant? If we left out for some time our blood sample, the serum is also comes in the supernatant form, but it is not a right because there may be a chances to present some amount of RBCs, some amount of red blood which may hamper. That's why we use tungstic acid to separate out hemoglobin from the blood and we use such plasma solution. So firstly we use test. In the test we get first in 1 ml distilled water. In which test do we add distilled water? Blank. Our standard is 100 ml per day. One ml. Okay. Now we add our coloring reagent. We divide here the reagent. The first one is coloring reagent. Coloring reagent which is 2 ml in each test tube. 2 ml in each test tube. Okay. And second one is acidic reagent which is again 2 ml in each test tube. 2 ml in each test tube. Okay. Then overall volume of each test tube is how much? 5 ml. Overall volume of each test tube is 5 ml. Okay. Now write it after the table. Mix it and leave for 20 minutes. ब्रैकेट में डालेंगे इंक्यूबेशन टाइम. लीव फॉर 20 मिनट्स ब्रैकेट में डालेंगे इंक्यूबेशन टाइम इन बॉइलिंग वाटर बाथ. इन बॉइलिंग वाटर बाथ. इन बॉइलिंग वाटर बाथ. इन बॉइलिंग वाटर बाथ. अंडरस्टैंड? क्लियर हुआ? बाकी सारे प्रैक्टिकल्स हम लोग इंक्यूबेशन टाइम कहां करते हैं? एट RT, एट रूम टेम्परेचर. बट ओनली दिस वी कैन टेक इंक्यूबेशंस इन बॉइलिंग वाटर बाथ. Okay, and take absorbance at 520 nanometer. Write it. Take absorbance at 520 nanometer. Take absorbance at 520 nanometer. OD of standard. Okay. Now the calculation. Calculation. Let a look of this calculation. Concentration of urea. iPhone किसका बज रहा है भैया ये? Concentration of urea is equal to OD of test upon OD of standard minus OD of blank minus OD of blank multiply by C upon V into 100. C upon V is the calculating factor which we cut it the value and we directly get 100 by OD of test upon OD of standard minus by OD of blank into 100. This is the calculative formula for this. Calculative formula. CYV is equals to 1. C is what? It is concentration of standard. V is volume of sample. Okay. Now write it the calculated formula. Lastly, you will make the heading. Student, lastly, you will make the heading result. 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 अभी एग्जाम में किसका हाईएस्ट आया था आपकी क्लास में? हाईएस्ट मार्क किसका आया था? ग्रेडिंग सिस्टम था, ग्रेड मिला था, ग्रेड। ठीक है, अच्छा रिजल्ट में लिखेंगे, राइट डाउन रिजल्ट, द वैल्यू ऑफ urea in given sample is dash mg per dl. Okay, mg per dl. This is the last statement of your practical. Student, why I am dictate you, why I am tell you the writing protocol of this practical? You just follow this protocol in your exam. In the examination hall, you don't confuse what you want to write it. To write it in this pattern, first to write it all this principle, calculation, write the principle and write the result. Okay. Now write it in another heading, clinical interpretation. Clinical interpretation. Clinical interpretation. इसमें आता है नॉर्मल वैल्यू ऑफ यूरिया. इसमें मेल फीमेल दोनों में कंसीडर करते हैं. इट इज 15 to 45 mg per dl. This is the normal range of the urea. 15 to 45 mg per dl. Okay. If the value is increases from the normal one, we call the term, very good, hyperuremia. If this value is low, we call hypouremia. Okay. It is hypouremia and hypouremia. Student, there is a one term comes, it is uremia, the presence of urea in the blood. It is called uremia. And second term is azotemia. Azotemia is what? It is presence of total nitrogen in the blood. Presence of total nitrogen in the blood. Okay? Presence of total nitrogen in the blood. But here you understand, after that you understand how can we calculate the burn. Burn is what? Blood, urea, nitrogen. It is total nitrogen present in the blood. How can we calculate it? It is directly calculated by this factor, by this. You understand the factor? That is concentration of urea. Listen carefully and write it. Concentration of urea is directly multiplied by 0.4617. So this is a factor. This is a factor through which you can calculate the burn, blood, urea, nitrogen. How this factor comes? How this factor comes? You already know. What is the molecular formula of urea? CO whole twice. The molecular weight of this urea is 60. Okay. And the nitrogen molecular weight in this whole formula is 28. So to make the factor, it is 28 by 60 and the value is come 0.4617. This is the factor come by this equation. So azotemia is what? Azotemia is the total nitrogen present in the blood. If we talk about the urea, that is called uremia. Total urea present in the blood. It is called uremia. Okay. Now you are not confused with uremia and azotemia. Now there are some cause of hyperuremia. You understand what I tell you? Students, urea and creatinine both the important factor to assess the function of the kidney. Understand? Because there is a filtration occur, blood is filtered in the kidney. If there is any kind of diseases which causes the function of the kidney, which disorientate the function of the renal, so ultimately what? They can increase the concentration of the urea. If I will write about the causes of hyperuremia, that is called, please silence the phone, otherwise you left the class. Hyperuremia, the causes are first either AKD. AKD stands for acute kidney disease, or CKD. Now all of you tell me one question. How will you confirm that the person having acute kidney disease with urea and creatinine? If I will tell you the value of urea increases, but the creatinine value is normal. So what are the conditions? You can say this person are affected from AKD, acute kidney disease. Yes or not? You tell whether it is affected from kidney disease. Yes? Yes? Not? Yet don't know. Yes. How many students agree that these persons are having the high level of urea and creatinine with normal and suffer from kidney disease? How many students think about that? Raise your hands. How many students don't know about this answer? अभी किसी से कहो ना कल पिकनिक मनाने कौन जाएगा, सारे हाथ खड़ा कर देंगे, पर लेकिन इस क्वेश्चन पे हाथ खड़ा नहीं हो रहा है आप लोगों को. हाँ? What I tell you, how can you confirm that these are person become affected from any kind of disorders related with the kidney? हाँ तो उसे क्या? It is filtered in the kidney. It is filtered in the kidney, na? But it is not a condition for a diseased person because urea is depend on protein diet. I clearly mentioned the value of the protein, the value of the urea is depend on protein. If a person is taking high protein diet, that ultimately it increase the value of the urea. But creatine value is normal because their renal function is good. GFR is fine. Okay. So in this condition, person are normal, but urea level may increase. So you are not interpreted anything. If I will talk about hyperuremia be caused by the AKD or CKD, you ultimately think that in this condition, both urea and creatinine increase in the blood. Where it is increase? Increase in the blood. Okay. Because it is mainly increased by the impairment function of the kidney. And this urea is increased by the protein diet or by improper function of the kidney like AKD or CKD. So both the cause can causes the value of the urea. Understand? But you will confirm that if a person having AKD or CKD, the creatine value is also hampered. It is confirmed. So that's why we called as creatinine is a very important sensitive parameter for the function of kidney, to check the function of the kidney. Okay, like in the case of AKD, UKD. Okay, in the case of diabetes, urea value may hamper. Okay, and by high intake of protein diet. High intake of protein diet. Okay. High intake of protein diet. Now, hypo, where the urea is synthesized? In the liver. Oh, so like in ALD, in the case of ALD, ALD stands for acute liver disease. Okay, in ALD, the urea level will come down. Finally, in the case of liver cirrhosis, liver failure, and lastly low protein diet, and lastly in the PEM. PEM stands for protein energy malnutrition. Protein energy malnutrition. Actually, PEM generally seen in child. When we talk about PEM, there is two disorders are comes. The first one is Kwashiorkor. Very good. And marasmus. So in this such type of child, there may be a low level of the urea, but it is not confirmed. But in all the cases, there are hypouremia and hyperuremia. Okay, so you can complete all this practical in your final copy, and in the next session we perform this practical in the classroom. Okay.